you need to, like, sometimes I have to touch the slides to get the video working. You can do that with this or no? Sometimes you have to, or maybe take it off. I just want to thank Angela for the kind invitation, the hospitality, the chance to see the beautiful Tenerife, and also her whole staff in the clinic that did so much work to prepare this wonderful symposium. So I want to congratulate Angela for such a great job. Yes. Yeah. Okay. So I'm going to make this very practical with some cases, nothing to disclose. As everyone knows, the importance of imaging, you help stage the endometriosis, map fibroids, distinguish adenomyosis from fibroids preoperatively. You can tell mobility, adhesions, cul-de-sac nodules. So you have an approach prior, and you could counsel the patient regarding laparoscopy, robotic surgery, laparotomy, hysteroscopy, and get the right help or general surgeon if needed. So the impact of fibroids still remains an area of debate. It's associated with subfertility in 5 to 10% of cases, but probably just singularly responsible in just a few. But what's not controversial are submucosal fibroids or intramural fibroids that are impacting the cavity, and they are associated with reduction of pregnancy rates and implantation rates. So why 3D for fibroids? We don't have to convince this group here, but 2D, you have basically this one here. I didn't try it. So you have your fibroid, and then with 3D, you have, does it go this way or this way? The pointer, oh, you have to, it's not so, oh, there it is, second one. Okay, with 3D, you get this coronal view, and you can see the exact placement of the fibroid, and you can see clearly this fibroid impacts the cavity, and this is one that you would want to remove. You also want to measure this, the serosal distance to the fibroid, because if you are close to the serosa, and here too, where you have just a little bit of impact, you don't want to take a hysteroscopic approach. You want to remove it laparoscopically through the serosa. And you can use the 3D saline sonogram as well to clearly see your fibroid. And here's another one with the fibroid, fundal fibroid pushing into the cavity. So the staging of the fibroids are based on either no invasion or the percent invasion into the uterine wall. And the type 2 fibroids are tricky hysteroscopically to remove, and also depending on how close they are to the serosa, you may have to remove them laparoscopically. So here's your omni view. You can go with lines through the endometrial cavity, and you can see clearly the placement in your views of the fibroid. So that's a helpful way to do it. And your saline sonogram here you have clearly with the saline sonogram, you can see that the majority of the fibroid is inside the cavity. And this approach you would do hysteroscopically. And this is the fibroid that was seen from the saline sonogram. And it's clearly, you can also see where the attachment was from the imaging. And we use a lot of these morcellators, mechanical morcellator. This one's a MyoSure, that you can morcellate the fibroid and completely remove it. So when you have a number of fibroids, we had done this study years ago and presented to AAGL that if you have more than 5 fibroids on 3D ultrasound, then it seems to underestimate the number of fibroids at the time of surgery. But the MRI was not very different, slightly better, but it's really not that different. But I tend to get an MRI for patients who have like more than 8 fibroids. Just in some cases you get a better picture. But here you have an intramural plundal fibroid, and you have a fibroid that is submucosal, and then you can use the famous TUI to be able to see the extent of where the fibroid is, and where here there's definitely a submucosal component to the fibroid. So at the time of surgery, you are removing, well, you clearly saw 2 fibroids, so you want to remove the one at the fundus, and and then the second one, you would expect it was submucosal, so you entered the cavity. But if you are doing a laparoscopic case as well, you're still not going to remove the other one hysteroscopically, and then you repair and suture the cavity. So you know exactly where you lose that tactile feel. Laparoscopically, you have to map them and know exactly where they are placed. So here you want to make sure that you close the cavity in layers, and you don't want to get suture in the cavity. And another example of this is ideal not entering the cavity. And then you can, so this is the uterine cavity clearly seen. So laparoscopically, you want to close the cavity in layers. And these barbed sutures have really made life much easier for us laparoscopic surgeons to do myomectomies. Very rarely do we open a patient unless they have like 36-week size fibroid uterus. So the cavity, and these patients, you don't see much adhesions. This is the straight sticks versus the other was a Da Vinci, but and then so you close the serosa separately, and the patient is ready for her surgery. I mean, for her pregnancy. Now, I don't know if you recommend, most of our patients who are going for IVF or infertile, we tell them 3 months they can start trying, rather than some of the OBs tell them 6 months or a year. Okay, so afterwards, we do a ultrasound to show that there's no more fibroids, and this is a patient post-op 4 weeks. You can see the suture still, the echogenicity of the suture, but the uterus looks quite normal. So we're going to talk about adenomyosis. That is migration of the endometrial glands and stroma from the endometrium into the myometrium, and it's associated with smooth muscle hyperplasia. So you have asymmetrically enlarged fundus. This is very common, where it's associated with the, usually one side can be thicker than the other, and you see these hypoechoic linear striations that we call Venetian blind striations, and the endometrial myometrial border is usually a little fuzzy. So this is classic adenomyosis. This is a 3D image of a normal junctional zone. So here's the junctional zone shown in the arrows, and this is a normal uterus. With adenomyosis, you're going to see this here's a dark halo on one side, which is common. On the other side, you see diffuse hypoechoic area on the left. And this is classic of adenomyosis, where you have thickening of one side. So this junctional area, you can have increased peristalsis, and it may affect the sperm transport and implantation. So it's a little controversial as well. If you have recurrent implantation failure and adenomyosis, you may want to treat the uterus with some either GnRH agonists prior to transfer if they're not getting pregnant. This is the MRI. You see increased intensity of adenomyosis. You see that increased junctional zone hyperplasia and these cystic spaces. So these are some of the characteristics of adenomyosis, and you can diagnose if you have at least 2 positive findings. It's about 85% accurate for adenomyosis. All right, so here is a clip. So this is, that was quick. So you can see adenomyosis here, increased thickening of the anterior wall and enlargement of the anterior wall. And then if you put on color, you're going to see more diffuse color in the uterus rather than color around a specific capsule. So you're going to have diffuse spread of the vessels. So I'm going to do some cases, and if you can ask questions later or interrupt. But so this is a 32-year-old P0 who has severe dysmenorrhea, and she wants to conceive, she requires 30 of Advil during her period. You always want to know if her periods are regular, last period when you do an ultrasound, and if they're on birth control. So you suspect endometriosis. This is called like a question mark sign when the uterus is retroflexed, and you could see this rectosigmoid nodule. So you can diagnose endometriosis lesions in the rectosigmoid area, and it's good to know before you go in, because sometimes the nodules are hidden when you go in for a laparoscopy. It may not be obvious, but if you know to look for them ahead of time, you can do a better job in resection, especially if the patient's having pain. Here's an MRI. Here's the nodule, which is a low intensity mass on the MRI. Here's your and the ovaries are, so you have the ovaries stuck. Then there's something called the sliding organ sign that we use a lot. So the ovaries may be stuck, and you look at, and they may be at the level of the by the cervix or the torus. And I'm going to show you some clips. And so sometimes the endometriomas could be kissing. And what you do is, so you go in gently with the probe, and you go in the anterior cul-de-sac, posterior cul-de-sac, and assess mobility, elasticity of the structures, and whether they move separately or not. So you move the probe left to right, up and down during your exam. So here's clearly you have the endometrioma, which is stuck posterior to the uterus, and they don't move separately. And some other examples of this endometrioma in this patient. So you would expect at least stage 3, stage 4 endometriosis. Uh, there's the uterus. The right ovary has, so you have a classic endometrioma with the ground glass appearance. So here's the classic findings: the thin wall, unilocular, this ground glass appearance, no flow by color Doppler. So in fact, we had a case here. This is clearly endometrioma, so you have flow around. But if you look at this versus this, they both look like endometriomas, but one has blood flow into the cyst, the other one doesn't. And this was actually an endometrioid carcinoma, and this was the endometrioma. So you have to be more suspicious. So you should put color flow on your endometriomas. Here's an example of like a you could see the ureter here. It's fibrotic. And then this is the ureter. So you have hydroureter, and you can see the distension and the fibrotic area of the ureter. So you would know that this would require possibly urologist or a expert surgeon. And you can see this is one of deep infiltrating endometriosis nodules posterior to the uterus. So you can see endometriosis. We've actually had a case of endometriosis in the bladder, so you want to drain the bladder and make sure you don't have any nodules. But those you have to treat just with GnRH agonists, and they usually respond very well. So this was the findings on the patient. So she had a cul-de-sac obliterated by adhesions, a bowel posterior, her right ovary, her left ovary. They both had endometriomas. Now the tubes were normal. The tubes are pretty spared. So this patient, even though we didn't have so much promise, wanted to try to conceive first without IVF because she had the surgery and it was done for pain. So she ended up going to do IUIs. It didn't work and ended up doing IVF. So the question is, when should you operate? Should you operate with endometriosis? If they have minimal pain, primary infertility, most of the time you don't want to operate, especially if it's stage 3, stage 4. This is pregnancy rate and based on age. So the younger patients you can try surgery first if they're symptomatic, but definitely the older patients, you want to go straight to IVF, not waste a lot of time. And this is the IVF success based on age in stage 1, stage 2, stage 3, and stage 4. So there's an endometriosis fertility index that may be helpful based on historical age, history of infertility, years, prior pregnancy, and then the score at surgery. So a surgeon who's skilled can tell, like after the surgery, should they go straight to IVF or you give them a chance. And these factors are based a lot on the function of the tubes, if the tubes are functional or not. And you get a higher score if they look totally normal or if they're not. It depends on adhesions too. So based on this, they have validated this endometriosis fertility index. David Adamson was the one who first reported it. And so they can estimate based on the score who's going to get pregnant and who is not. And it's very useful if they do go to surgery. But if you have other issues, a damaged tubes, definitely abnormal sperm, you need to go to IVF and not waste time. So another case, another patient with increasing dysmenorrhea and symptoms, and they thought she had a fibroid uterus, but when we did our ultrasound, it was more of a uterine anomaly, and this is the leftover. So it is a didelphys uterus with 2 cervices, and she was having pain, so she wanted to go for surgery first. Here's color Doppler, so there's a lot of blood flow between the 2 horns. And you could take it. So actually the 2 cervices were very close. They were so close together that you went in a single opening, and then you went right and left. And MRI, you don't really need if you have like a normal picture. HSG, you were able to show patency of both sides. But here is her MRI. They actually diagnosed her as a bicornuate, not as a didelphys. And at hysteroscopy, there was a small fibroid on the left horn. The right horn was normal, so that was resected, but she did have a lot of endometriosis that could be associated with anomalies. That was resected, and we encouraged her to go to IVF because she was also a little older. And we transferred, here's where you PGT based on age and also based on absolutely transferring a single embryo in a uterine anomaly. So she had PGT tested embryos. She had 3 embryos that were normal. The first one led to a miscarriage, and the second one she delivered at 35 weeks. So she was successful. So the uterine anomaly talk yesterday was excellent, but as you know, we don't have to convince you about the coronal view is so important because you could see the serosal fundus, the endometrial fundus, and the lower segment. And we heard about that. But this is definitely a didelphys because you have a lot of bowel right between the 2 horns are separated. This is your septate. 2D, you can't really diagnose it well. 3D, your partial septum. And this was, we were talking about that yesterday, but we used to use the resectoscope in this roller ball, and it was very, very quick. And now we get away from the cautery and do more scissor or a combination of a scissor to start and the mechanical morcellator to finish. But the morcellator doesn't work for the whole thing that well. It's really until you start with the scissor. So rudimentary horns are easy to diagnose with the 3D. This was just, here's her MRI. So a rudimentary horn, if she's having pain and it's not connected to the cervix, we ended up resecting, like doing a little hemihysterectomy and resecting the uterine horn because you can get an ectopic pregnancy. So it's recommended if you remove the horn, you should remove the tube on that side to reduce the ectopic pregnancy risk. And this was done. So you can diagnose them as just as well. And the good thing with the imaging, you can tell if the horns are close together or not, and what to expect there. So this was done with a harmonic scalpel, and then we repaired the uterus. Then just a few more things. Fallopian tubes this is easily seen. You see the cogwheel sign and the fluid in the tube, and then you get that beautiful 3D rendering picture. So this patient actually had a normal HSG. She had IVF and 2 transfers, and it failed. And then we decided, then all of a sudden we saw the hydrosalpinx on the ultrasound, and she was questioning, did we miss it, blah, blah, blah. But she had a normal HSG like a year and a half prior to the IVF. So we're not quite sure where it developed, but then, so we removed it, and she had all this endometriosis with the hydrosalpinx. And then finally, she conceived after surgery. So we did a salpingectomy and removed a lot of the endometriosis robotically. So REIs still should do surgery to improve IVF success, and just you got to know how to do it, or when to do it, and who's the right candidates, and also be able to counsel your patients, and that's why the imaging is so important. So this is a little controversial. I'm interested in knowing your feedback. The patient had 3 IVF recurrent implantation failure, 3 IVF transfer failures. So then she had the Receptiva test, and she had a positive BCL6. So she had unexplained infertility for 2 years. some dysmenorrhea, irritable bowel symptoms, but she had a prior laparoscopy. It was negative by her OBGYN. And she had when you have recurrent implantation failure, you think about endometriosis. And she has one euploid embryo left. So what would you do? Would you do another laparoscopy? She still has some symptoms, but then they didn't see anything. This is so there's one study by Likes and Jard. This is the studies that they published showing a benefit in GnRH analogs or laparoscopy in brown GnRH analogs versus a control group of no treatment in recurrent implantation failure with a BCL6 positive patients showing benefit in clinical pregnancy rate, live birth rate, and lower miscarriage rate. Is this something popular in your here? I mean, in this particular patient, I don't think it's probably not, there's not a lot published, and there's just personal experience. It's not like the full answer, but in this patient who's had 3 transfers and it's negative, we'd treat her with the GnRH analogs and not do the surgery and do the 2 months of Lupron. There's another study showing that letrozole with Lupron also may have a beneficial effect with the combination, but nothing with the Orlissa that we've seen. So in the final case of the Isthmocoele, this is also so secondary infertility, trying to conceive for a year, normal studies, and she had the abnormal ultrasound. She had 1 C-section, and here's the 2D, and you can see the Isthmocoele. So here's the uterus here, and the endometrium, and here's the defect. So this is the Isthmocoele at the point of the C-section scar. And here's the Isthmocoele on 3D. So this is another area. I mean, I don't know also how you feel if you're repairing them all, but we're just recommending repair if there's fluid in the endometrial cavity or any kind of chronic inflammation or endometritis, or if it's a large, but usually you can do the transfer and bypass it and just under guidance. And it's so common that, if you see a small Isthmocoele and they're not having drainage into the cavity or vaginal discharge, then we're not repairing them all. I don't know. Also, we can talk about these things later. Okay, so that's about, and this is on MRI. You can see the C-section scar and the Isthmocoele here, but you don't really need MRI. Okay, so in conclusion, the 3D ultrasound has revolutionized pre-op evaluation of patients. So it's important for the surgeon to do their own. You could do the pain mapping. You could pick up things that a report may not be able to. If you do have a ultrasonographer do the mapping for fibroids, you want to know the exact location of every fibroid, the size, and the type it is, and they should characterize based on the FIGO staging. And we rarely require MRIs. I said just based on the study, like if a patient has like more than 6, 7 fibroids, the MRI seems to get a little better picture for preoperative evaluation and to decide if it should be an open case versus a laparoscopic case and really map them all. But the importance is to be able to counsel the patients ahead of time. And yes, you can diagnose endometriosis by ultrasound, even sometimes at lower stages, and that's one of the diseases that on the average takes 8 years to diagnose. So we require the GYN should have more experience in their ultrasound evaluation. Okay, thank you so much.